Hello, my name is Patricia Hall Eidson, and I currently serve as the Diagnostics Team Lead in the Global Program on TB and Lung Health at WHO headquarters. It's my pleasure to be welcoming you today to the TB Diagnostics section, or Day 2 of this workshop, providing an overview of the day and providing you with some background information as well. So for this testing section, I have a series of objectives. The first is to review global TB testing priorities and region progress towards universal patient access to diagnostic and drug susceptibility testing services. The second is to learn about new WHO TB testing policies, operational guidance, and regional tools to support the implementation of the recommendations. And the third is to consider how new WHO guidance and within region experiences that will be shared between your colleagues today could strengthen country testing programs to achieve global testing targets. So this is a quick look at the agenda for the day. We're starting with this session where we will be reviewing the advances in global and regional diagnostic programs and policies. Then you will move into a section where you'll be provided with policy updates on the initial detection of TB and drug-resistant TB using WHO-recommended rapid diagnostics. You'll learn more about a WHO Euro course, and you'll be presented with a country experience. Next, you will be presented with policy updates on the detection of drug-resistant TB using next-generation sequencing, receive an overview of a WHO Euro tool related to sequencing, and have another country experience presented. This will be followed by a working session where the updates from the day, new WHO policy guidance, and cross-country experience sharing can be used and prioritized using a KNCV tool to guide national TB laboratory strategic planning efforts. So to begin, I'd like to take us through an update on the global and regional TB testing priorities and our progress towards achieving targets. WHO Global Program on TB and Lung Health through the NTB strategy, for which there is an Implementing the NTB Strategy Essentials document shown here on the left, recommends TB diagnostic and drug susceptibility and TB infection testing as all essential for integrated patient-centered care and provision, or Pillar 1 of the NTB strategy. In this figure, the green circles highlight two of those components, specifically the importance of early diagnosis of TB, including universal drug susceptibility testing and systematic screening of contacts and high-risk groups. And the second is the preventive treatment of persons at high risk and vaccination against TB, for which TB infection testing is useful. Despite these recommendations, we see, according to the latest WHO Global TB report published in 2024 with data from 2023, that approximately a quarter of the world's population had been infected by TB, and there were an estimated 10.8 million incident cases, of which 8.2 million were identified and notified to WHO by WHO member states. Of those notified cases, only approximately 48% were tested with a WHO-recommended diagnostic to identify or diagnose TB disease. The variability in testing is shown in the purple map on the right, which shows the percentage of people newly diagnosed with TB that received this WHO-recommended diagnostic testing, or WRD testing. We can see here that the Euro region has experienced some strong success in WRD coverage, and we'll talk more about that in just a moment. Of those 8.2 million notified cases, there were approximately 400,000 multi-drug resistant or RIF-resistant TB cases, abbreviated here as MDR-RRTB. However, less than 50% of the estimated number of incident DRTB cases were diagnosed globally that same year, where diagnosis often relies on drug susceptibility testing. Of those with bacteriologically confirmed TB, only 79% were tested for rifampicin resistance globally. And of those with rifampicin resistance, only 55% were tested for fluoroquinolone resistance. And we continue to see low and variable rates of bedaquiline and linezolid resistance testing globally, highlighting that we still have opportunities to ensure that clients receive these services, can be started on appropriate treatment, and can be guided towards cure. As I mentioned, the Euro region has achieved increases in the coverage of WRD testing for incident or new cases of global TB. The global proportions are shown on the left over time, where the percentage has increased but has plateaued since recovery from the COVID pandemic in 2022. However, in the European region, we see that it is one of the only two regions where 80% of the population received WRD testing of those that were newly diagnosed with TB in 2023. In addition, we see high overall proportions of rifampicin resistance testing among patients with bacteriologically confirmed TB, as shown in the circled figure. And you can see, compared to other regions, this is a great success and has remained at a high level since 2018. Among those with rifampicin resistance, the European region also achieves relatively high levels that have been sustained for many years, with a dip in 2022 that has re-increased again to 2023. And it will be great to see this advance even further towards the target achievement of 100%. For global bedaquiline resistance testing, as was stated earlier, this remains low and variable, but the European region has established strong capacity for bedaquiline resistance testing. This is similar for linezolid resistance testing, with a greater level of variability globally and within the region. To assist member states in achieving universal coverage to testing services, WHO recently released a standard for universal access to rapid TB diagnostics. It is shown on the left and can be found online. This standard includes 4 steps, mimicking the patient pathway through service provision and care. The first is the identifying presumptive TB step. This is to increase the number of people with presumptive TB in care. The second is that those that are identified with presumptive TB should access testing. And the goal here is to increase access to WHO recommended rapid diagnostics. The third step, shown in teal, is those accessing testing are tested. So increased WRD and drug resistance testing. And then step 4 is these individuals receiving a diagnosis. So this goal is to increase WRD-based diagnosis. These 4 steps include an overall total of 12 benchmarks, and member states began reporting this benchmark data last year for the first year. Step 1 includes 2 benchmarks. The first, or benchmark 1, shown on the left, is all household contacts, all PLHIV, and all other locally relevant high-risk groups are screened for TB. Benchmark 2 includes all districts. Chest X-ray is used regularly for TB screening, and that is to support the identification of presumptive TB. For step 2, we have 4 benchmarks, 3 through 6. These are the ones shown in orange. In all facilities and all districts, the TB diagnostic algorithm requires the use of a WHO recommended diagnostic as the initial test for all individuals with presumed TB, including children and PLHIV. And we're going to hear more about those populations in our new policy guidance later today. Benchmark 4 includes all primary healthcare facilities having access to WHO recommended diagnostics on-site or through sample referral. Benchmark 5 states that all individuals with TB have access to WRDs as the initial diagnostic test. And 6 highlights WRD testing capacity meets the expected needs, including surge capacity, according to the latest data. Those are all related to accessing testing. And then we move to step 3, where there are 3 benchmarks, 7 through 9. Benchmark 7 is a monitoring of instrument functionality, where an error rate is less than or equal to the recommended 5%. Benchmark 8 is where all individuals with presumptive TB are tested with a WRD, and benchmark 9 indicates that all patients with bacteriologically confirmed TB undergo universal drug susceptibility testing. This is broken down in the reporting according to the drug resistance testing category: rifampicin, fluoroquinolone, bedaquiline, and linezolid, according to the importance of the new BPOM regimen. Step 4 includes another 3 benchmarks. So these are the benchmarks related to persons receiving a diagnosis, where benchmark 10 is all patients with pulmonary TB receiving an initial WRD result to inform their diagnosis. Benchmark 11 is all districts monitoring the test positivity rate to optimize the impact of their screening and their testing strategies. And benchmark 12 is all testing laboratories achieve a turnaround time of less than or equal to 48 hours for greater than or equal to 80% of samples received for WRD testing to ensure timely diagnosis. So this is what the global reporting from high-burden TB countries and those prioritized by WHO regions for reporting on the standard looks like. So this is data reported last year by country. So this was the first year of global reporting on the standard. It included up to 65 countries. You can see the number of our countries that reported on each of the benchmarks listed below, where the benchmark titles are summarized and they are colored by steps. So the first 2 benchmarks, people screened for TB and the percent of districts with chest x-ray, are related to step 1, for example. Unfortunately, only one of the benchmarks achieved 100% reporting by member states. And in order to calculate these benchmarks, what we mean when we say 100% reported was both the numerator and the denominator could be reported on. So, for example, in the first benchmark, the percent of people screened for TB, in order to be fully reported, countries would have needed to report on how many people were eligible for screening and then how many of those that were eligible were screened. That is how the percentage is calculated. And you can see there were gaps in reporting based largely in follow-up discussions, we believe, on data availability, suggesting that some of the data elements that are required for countries to monitor their progress towards universal access to testing could use strengthening. However, we did see several benchmarks achieve high levels of reporting even in the first year, including the percent of cases that were initially WRD tested with more than 60 countries, the percentage of cases with rifampicin resistance results available. This is also an indicator that has been included in the Global TB report in prior years, and the percentage of RIF-resistant cases with fluoroquinolone test results. Again, a Global TB report indicator. What I'm showing you now is the WHO standard reporting for the European region, for which 8 countries were invited to report. And you can see the results are similar in reporting data availability and data access. The ones with the orange stars are those below the 80% achievement mark. So those for which less than 6 countries could report on in the first year. Countries are undergoing a second round of reporting this year at the same time as WHO is collecting data for the Global TB report. And so we do hope that after the first experience of reporting, getting used to the new indicators and having a year to strengthen data availability and reporting to WHO, that we will see this reporting increase. But I'd like to highlight a couple of trends here. So when we look at the benchmarks for which 80% reporting was not achieved in the first year, we see that they include the percent of people screened for TB, the percent of facilities with WRD access, the percentage of tests required to test all presumptive individuals, the percentage of presumptives tested with WRD, the percentage of cases with WRD testing, the percentage of districts monitoring the test positivity rate, and the percentage of testing sites with a 48-hour turnaround time. Some of these we know are likely to be much higher when countries have the data on hand and are able to report both the numerator and denominator. So, for example, the percentage of cases with WRD recommended diagnostic testing. We covered that the proportion of WRD coverage in the region is actually quite high. And so we anticipate that this may be a data reporting challenge and not necessarily a low proportion of coverage, for example, of cases with WRD testing. However, 3 of these are related to data elements related to presumptive TB cases. And so it will be interesting to see and to have discussion in your groups today around whether or not having access to that data is a challenge or whether reporting it was a challenge during the first year. However, for those benchmarks for which at least 7 of the 8 European region countries could report, these were the percentage achievements, and these can be found in our online WHO standard database website, which can be found by accessing the WHO Global TB Report website and going to the data section. So quickly to review, this was the performance reported. For benchmark 2, in all districts, chest X-ray was being regularly used for TB screening across 91% of 542 reported districts. For benchmark number 5, all individuals with TB have access to WRD testing as the initial diagnostic test. This was reported as 92% achievement, which is great and reflected a total of 96,308 people in the region. When it came to benchmark 9, as I indicated earlier, these are separated according to bacteriologically confirmed TB, rifampicin resistance, fluoroquinolone resistance results, bedaquiline and linezolid resistance results. And we can see that for benchmark 9A was achieved at a high rate of 97%, that all persons being notified with rifampicin-resistant pulmonary TB with fluoroquinolone DST results was also very high at 95%, but that the levels for bedaquiline resistance result availability among rifampicin and fluoroquinolone-resistant individuals were a bit lower in this most recent, in the first round of reporting at 67% and at 71% respectively, indicating that there has been progress, but there could be further strengthening of these drug susceptibility testing programs. So in summary of the global and regional TB data on testing, access to WHO recommended rapid diagnostic testing has plateaued globally, but it continues to increase in the European region, and this is really a great success. The European region has greatly advanced towards universal drug susceptibility testing for rifampicin, which is incredibly important to guide initial treatment decisions around drug-resistant and drug susceptibility or drug-sensitive TB. The WHO standard for universal access to rapid TB diagnostics highlights opportunities globally and in the European region to improve monitoring of test performance indicators, specifically around positivity rates and turnaround times, to further strengthen reporting or availability of WRD testing among persons with presumptive TB, and to advance access to drug susceptibility testing for new and repurposed TB drugs, in particular bedaquiline and linezolid, important again for BPOM and other bedaquiline-containing regimens that you'll hear about this week. With continued advances in TB diagnostic and drug susceptibility testing services, the European region is well placed to achieve universal access to testing, and we look forward to supporting you towards target achievement. Thank you very much, and I wish you the best with the rest of the sessions.